think about the other things that can cause respiratory distress, wheezing, that may not be, quote, asthma.
Welcome to the Evidence-Based Urgentology podcast from EB Medicine, where urgent care meets evidence. I'm Joe Toscano, Senior Research Editor for Emergency Medicine Practice and a member of the Evidence-Based Urgent Care Editorial Board.
Hi there, and I'm Tracy Davidoff. I'm Editor-in-Chief of Evidence-Based Urgent Care, and we're practicing urgent care physicians with years of experience, probably too many years of experience, on the front lines. And for us, diagnosis is detective work, and the clues are in the history, the exam, and of course the evidence. That thrill of solving the patient's puzzle is really what keeps us coming back.
Each month, we unpack the latest issue of Evidence-Based Urgent Care, tackling common chief complaints from presentation through diagnosis to disposition. We highlight the best evidence, the key takeaways, and the clinical pearls.
And by the end of every episode, you'll have sharper skills, deeper knowledge, and more sound strategies that you can use on your very next shift. So let's dive in. The evidence starts now. And remember, you can always find more at www.ebmedicine.net.
Hey, welcome everyone.
I never get to say the promos, so I'm going to say the promos this time. It may sound kind of weird with me trying to sell something, but that's okay. We have a podcast exclusive promotion, so if you use the promo code podcast in all caps, you can get 10% off your subscription. Plus, you'll also get the free Points and Pearls, the year in review for 2024 and 2025, which is $794 value. And this highlights all the key clinical insights for the past 2 years, kind of makes it a little quick read. And then we also rolled back our pricing to reduce barriers and make trusted evidence-based education easier for clinicians to access. If you want to see our new pricing, go to the ebmedicine.net website. And if you want to hit a /subscribe, you'll find the specific offer.
Perfect. This month, we're going to talk about the management of acute asthma exacerbations in urgent care and update. This is the June issue. And Tracy is one of the authors, along with Chris Chow, and actually I get to talk to both of them. So Chris is medical director of the urgent care at Wake Med Health and Hospital in Raleigh, North Carolina. And Tracy, attending physician, Bay Care Urgent Care, Tampa, Florida, assistant professor, family medicine, Florida State University College of Medicine in Tallahassee, and co-host of the Urgentology podcast. I'm going to pose some questions to you guys. In the issue, you guys talk about managing exacerbations, but also some of the things that have changed in asthma care in general. Exacerbations is about the same. You guys talk about what we shouldn't be doing as urgent care clinicians, but I think some of the changes are in the baseline care of asthma on a day-to-day basis. A lot of the issue talked about that. Along those lines, inhaled corticosteroids have been recommended as part of preventive therapy for patients with moderate or severe asthma for quite a while, and even patients for mild persistent asthma, right? But what's new about the new GINA guidelines in terms of asthma care in general and what we need to be conscious of in urgent care?
I think that's really a great introduction. From my perspective, I was always taught when someone comes in with an asthma exacerbation, reach for their rescue inhaler. And for most years, the rescue inhaler has always been a short-acting beta agonist. We know that mostly as albuterol. More recently, there's levoalbuterol, which is an isomer of albuterol that is reported to be cleaner with less side effects. But really, the two are pretty much equivalent. So albuterol is still pretty much the standard of care. What has changed in the last few years is the concept of ICS rescue. Again, when I was in school, ICS was really taught as, oh, this is for severe asthmatics because you don't want to be using it. Doesn't really help with acute asthma exacerbations, and there's potential side effects. But what has been found through research is, number one, short-acting beta agonists are not benign medications. That overuse of short-acting beta agonists actually increases risk of exacerbations, risk of morbidity and mortality. And the thought is that by overusing beta agonists, you're saturating receptors, which make them less sensitive when you really need it. That's one of the theories that is floated out there. But more importantly, the basis of asthma is inflammation. And we never address inflammation with a short-acting beta agonist. That's where the concept of ICS rescue or ICS for the management of asthma really comes into play.
That's so crazy because if you think about the pathophysiology, we all know that asthma is those two things. And for years, we've been using albuterol and not addressing the inflammation. I almost feel like that's an aha moment. Why didn't we think of that sooner? Definitely makes a whole lot of sense.
Yeah.
The GINA report really started reflecting this. I think 2019 was the first time that they started saying for outpatient asthma exacerbations, when that patient is reaching for an inhaler on an outpatient basis, when they're walking around daily life, that there really should be ICS or inhaled corticosteroid, that part of that regimen,
Mhm.
either as needed, or if someone's on maintenance, you still use it as needed because you're addressing the inflammation. Every asthmatic has inflammation. There's baseline inflammation, and that's variable. It goes up and down during the day, depending on what the patient is exposed
Mm.
to. But if there's a trigger like exercise, cigarette smoke, influenza like illness, or URI, the inflammation can break through. When that happens, the patient starts getting symptomatic. They reach for their albuterol inhaler. It addresses the symptoms, but it doesn't address the inflammation. Eventually, the inflammation builds to a point where the patient has a severe exacerbation. And that's when they walk into urgent care with the complaint of, I can't breathe, I'm wheezing, I'm short of breath. Now, when that happens, from our perspective in urgent care, we still treat them like we have before. That is a short-acting beta agonist, ipratropium, nebulizer, oral corticosteroids.
Mhm.
And we discharge them on oral corticosteroids. But the opportunity is, how can we prevent them, or how can we reduce the risk of that patient coming in with that severe exacerbation or the exacerbation that needs medical attention?
Yeah.
I also want to mention it's really kind of interesting is that you said it was 2019 GINA started to mention this stuff. They've been on this bandwagon in Europe for years, and we're just starting to get around to it here in the United States. We always like to think of ourselves in the US as on the cutting edge of things, but we're kind of behind the times on this, right, Chris?
I think what's really frustrating is I think most clinicians recognize the importance of inhaled corticosteroid, but we are hobbled and we are restricted by red tape. That is, the insurance companies require prior authorizations. They deny access to inhaled corticosteroids, and it makes it very hard and challenging for urgent care clinicians to put patients on validated evidence-based guidelines. Tracy, is that your experience?
Oh, absolutely. I find the barriers to that are immense. We have a fairly high Medicaid population where I work. You know, they're working class, but they're still Medicaid and they want these medicines. They want to treat themselves properly, but I send it to the pharmacy and I get denied.
When they used a short-acting beta agonist, they feel better. There's no denying that when you are having an asthma flare, if you use your short-acting beta agonist, you're going to feel better. You're going to breathe better. The wheezing's going to decrease. So I think that there's also a challenge for clinicians because we are literally trying to convince a patient to try a new regimen that, to their perspective, works really well.
The old one's working. Why switch and pay more money, right?
Why switch it, right? So I think that's a second challenge that we have to pay attention to as clinicians. There needs to be education, and the clinician has to be confident of their delivery in order for the patient to be confident that is the right thing to do.
Definitely.
One of the questions that probably should be asked is, why do we care so much about acute asthma exacerbations?
Because we see a lot of them.
There's a couple of reasons. Number one is that any exacerbation can cause morbidity, mortality, hospitalization, death. Even patients with intermittent asthma can have an asthma exacerbation that puts them in the hospital or puts them in the ICU. Number two is every time someone has asthma exacerbation, we're still treating them with oral corticosteroids. We now know oral corticosteroids are not benign. There is both short-term and long-term negative effects, and the long-term effects are cumulative and irreversible.
Yeah, that's true. That's a really valid point. If you use the inhaled corticosteroids, you're less likely to need the systemic corticosteroids.
I can remember as a medical student, IMEPI used to be part of the treatment of many patients presenting with asthma, along with inhaled metoprolol and IV aminophylline. That was 40 years ago. Remember that?
Yeah.
Having to calculate the IV dose to the PO dose after a patient was admitted for a period of
Peaks
time.
and troughs of that stuff. Oh my
Uh,
gosh.
Crazy.
Yeah.
But of all of those, thankfully, we're not really dealing much with that. Although I've heard of IV aminophylline being used in the ICU for PEDS. asthmatic patients. Anyway, IM epi is still recommended in some cases. Some people might wonder if it's helpful even if the asthma attack's not associated with anaphylaxis. So what's the scoop there? When will we use that?
I think it works, right? It does work if you're super desperate and don't have any other choices, like you're in the middle of some jungle and all you got is an EpiPen to treat somebody's asthma attack. Maybe that's what you'd use. But for routine use, IM epi and inhaled epi, let's not forget about over-the-counter epi inhalers like Primatene Mist. We should be totally skipping epi, but Chris is about to jump out of his chair, so go ahead and talk.
When I was growing up, I'm showing my age here, guys. I remember those commercials.
They still are out there.
Yeah, they still have it on the show.
My understanding is that somehow along the way, it was discontinued or withdrawn.
Yeah.
But guess what? That
Yeah.
I personally think is a very dangerous product.
Yeah.
Because it does give people relief,
Mm-hmm.
but it doesn't solve any of the problems. Unfortunately, at least down in the South, there's a lot of use because it's available over the counter.
Yeah.
And the patients who may not have access to healthcare, they get desperate and they start using it.
I think the upregulation of alpha beta agonist receptors is even greater, which causes a lot more problems. I've had IM epi save my skin and patient skin a couple of times when you were doing everything, nothing was working, and then you add it in. It's certainly not first line, second line, but I've had it actually produce remarkable change in somebody who was getting continuous nebs. They already got their steroids, you did some MAG, even considered terbutaline. This was in the ED. But IM epi would make the difference in those really severe patients, not inhale. But I am in those cases. So something to keep in mind for severe flare while you're waiting to transfer.
Joe, I think that from an urgent care perspective, there's really no role for epinephrine. If a patient is really that sick, it needs to be EMS out of there.
Yeah. So keeping on the topic of managing severe asthma exacerbations, you guys talked about starting treatment while you're doing your history and physical, not necessarily going through the process, but start the treatment right away once you have an inkling of what's going on. What are some of the other things clinicians should keep in mind when they're taking care of those patients with severe asthma? Just like you said, awaiting transport. You get your nebs going, steroids, you're doing continuous nebs, sequential nebs. What's your management of your most severe patient?
It's still always airway, breathing, circulatory. Still start with the ABCs.
One of my big pet peeves is people who walk away. These people can stop breathing on a dime. I've done medical legal cases with asthmatics that were not expected to arrest and they respiratory arrest. When you have a patient that's that sick that you're sending to the ED and you're waiting for EMS, don't walk away to go write your chart. Don't walk away to go do whatever. You stand there with them, because if that patient arrests, you want not an MA standing there going, now what do I do? You want to be the one to stand there and start resuscitating them. Once you've made the decision that this patient is an extremist and I need them out of here, you need to stand there with the patient until you transfer care to somebody else.
Right. It's not like fainting when an asthmatic fails. They are hypoxemic, acidotic, pretty close to full code.
Yep.
I think the biggest pitfall that we need to be cognizant of is that wheezing depends on air movement.
Mm-hmm.
And so when someone starts getting into respiratory failure, you get decreased wheezing, but it's not because they're getting better. It's because the air is not moving.
Yeah.
Yep.
I've seen people fall into that trap.
Yep.
And you need to be, as Tracy said, you need to be very cognizant and you need to have eyeballs on the patient. If a patient is having respiratory distress / respiratory failure, because the traditional signs may not be there. You can get fooled very easily in thinking that a patient is improving when they're actually getting ready to code.
Yeah.
Yeah.
Wear the silent chest. Then they may actually increase their wheezing after that first treatment. And that's a sign that they're getting better if they're going from a small amount of wheezing because there's critical bronchospasm.
Look at the patient, not listen to the lungs. Obviously, you have to listen to the lungs, but if you hear clear lungs and the patient looks like they're crapping out, don't trust your lung exam.
Yeah.
The other kind of point too is that if you have a patient who's wheezing and they're not responding to short-acting beta agonists or other medications, your differential needs to be expanded too. Think about the other things that can cause respiratory distress, wheezing, that may not be, quote, asthma. And that is a time to really start expanding differential diagnosis. It's not going to change what you do. You're still going to EMS them out to the ED, but at least start thinking about other things that can mimic this.
Yeah, that's a frequent trap in
Yeah.
a patient who's already an asthmatic, because the patient is short of breath and they're an asthmatic. They're going to assume that it's asthma. So they're going to come in and they're going to tell you, I'm having an asthma exacerbation. And you're like, they're a little more tachycardic than they should be. Their lungs actually sound really good. Why are their legs swollen? I've had a few of those where the patient absolutely insists they're having an asthma attack. And I'm like, I don't think so. This is something else going on here.
Cardiac is
Yeah.
another thing that could be. And Tracy, I think that's a really good point. If you listen to the lungs and there's just not that much wheezing and they're short of breath, go back and reassess your differential diagnosis. You might be missing something.
I've had two not too long ago. One was an older lady who was insisting she's having an asthma attack, and I could literally hear her aortic stenosis without a stethoscope. And I'm like, did anybody ever tell you the heart murmur? And she's like, no, this is an asthma attack. And I'm like, well, I don't think so. She was in the OR the next day for an aortic valve replacement.
Yeah.
And another one that was influenza. I've had an asthma exacerbation because of my influenza. And she had seen 3 or 4 different providers who had treated her with steroids, who had treated her with a Z-Pak for her post-influenza bronchitis. And she actually had viral myocarditis, and her EF was under 20.
Wow.
I was like, okay, you're really short of breath. You're kind of hypoxic, but your lungs are clear.
Yeah.
This is a problem. And
Wow.
she actually ended up on a transplant list. So yeah, all that wheezes or all that patients think is asthma is not necessarily asthma.
Yeah. More of an anchoring bias.
2 of my more memorable asthma patients that ended up not being asthma was at a gentleman, this was probably 15 to 20 years ago, come into outpatient clinic and say that he's short of breath and wheezing, that he gets very short of breath when he's walking up the stairs. I look at him, he's white as a sheet.
Anemia.
Yeah, his hemoglobin was like 5.7, and it was due to a GI bleed.
Yeah.
He came in thinking it was asthma because one of his coworkers saw me, had asthma,
Yeah.
did real well with inhalers and a steroid
Mhm.
pack, and he wanted the same treatment. The other very memorable one was in pediatrics, where asthma was presumed, whereas the real diagnosis was foreign body obstruction / choking.
Yeah, that's a big one too.
Tricky one. Yeah.
Wow.
So what about pregnant patients? Should we be shying away of certain treatments for them because there's teratogenic potential, or can they experience complications to their pregnancy if their asthma is poorly controlled or exacerbations aren't properly managed?
A lot of asthmatics will actually get significantly worse during pregnancy, and a lot of people will actually have their first presentation of asthma when they're pregnant. Think about it, struggling to breathe and being hypoxic is probably not good for the fetus. So it can really cause a lot of complications and increase risk for those complications if you don't treat them properly. The good news is that everything that we do for someone who's not pregnant is safe in people that are pregnant. Same inhalers, same treatment in the clinic with the oral corticosteroids and the inhaled ipratropium and albuterol is fine. It's better to treat the patient than to not treat the patient. So don't shy away from pregnant patients who are asthmatics.
The concept that we teach is risk benefit. The risk of an asthma exacerbation is so much higher than the risk of the medication that we use to treat acute asthma exacerbations and for maintenance. That's really it. The benefit outweighs the risk here.
You guys cited, in addition to all the complications that any asthmatic could experience, a pregnant patient could experience, but then there's potential complications with the pregnancy when things aren't managed properly. I love the ankle sprain patient example you give, the one who asks for an MDI refill on the way out the door as the air gas is being put on. That's pretty common in my experience. It's almost like we're going to have to start over with re-education for those patients who just want that albuterol for the PRN use, and that's how they're managing things. Those seem to be the ones. It's very few people who say, hey, can you refill my Symbicort or my inhaled corticosteroids? It's almost always albuterol that they want. Maybe it's just part of that running out of things and not being on top of stuff that makes that be their preferred mode of therapy. But how are you guys handling that these days? How are you kind of winding that and getting people to understand that what they've been doing all this time is not the right thing?
Joe, I think it goes back to a comment that I made earlier. Our patients have been trained and repeatedly told, don't ever go home without your rescue inhaler.
Yeah.
And that rescue inhaler is a short-acting beta agonist. So some of this is retraining. It's very interesting. My first question when a patient asks me for a refill of a short-acting beta agonist is, why? Have you been diagnosed with asthma? Have you been on any treatments in the past? Why has someone giving you albuterol? And surprisingly, it seems that albuterol seems to be overprescribed for a whole bunch of other reasons besides asthma. Some case in points is a person comes in with a post-infectious cough. Oh, here's some albuterol. Patient comes in for bronchitis. Here's some albuterol. Oh, I have allergies and I'm coughing a little bit. Here's some albuterol. It just seems to be thrown around a lot. And so really the core question then is, of the patients who are asking for a short-acting beta agonist inhaler refill, is it even needed?
Yeah. Good point.
Because if they don't have asthma, there's no evidence in the literature that that's beneficial. There's no evidence in the literature that it is useful for post-viral cough, for bronchitis. I think you can eliminate some patients from a refill of albuterol just by having a conversation as to why you really need it. Now, if a patient is asthmatic, then the next question is, tell me what your asthma care plan is. A lot of them will be like, I don't know. Or they'll say, I just use this inhaler when I feel like it.
Yeah.
Have you ever been on a maintenance inhaler? Yeah, but I don't use it. So I think that opens the door.
Yeah.
We can certainly continue albuterol, but just be aware that the management recommendations for asthma have changed. And here's why.
Yeah.
That's my opening line. If you absolutely have no other alternatives, we will refill albuterol in certain circumstances.
Right.
But it's very difficult, knowing what I know and knowing the evidence, for any patient with bona fide asthma to walk out without an ICS somewhere.
And you talked about the red tape. I think that can really get in the way with these patients. There's the red tape too of formoterol budesonide and albuterol budesonide being something that should work and be good, but they're either not mentioned in the guidelines or not FDA approved for this, right? There's a lot of disconnects there, and they're both very expensive and hard to get for patients when that should be people's first line.
Joe, when you really dissect the GINA report, there's actually two tracks. Track one is their preferred track, which is formoterol, budesonide, PRN, and then adding on an ICS LABA plus budesonide and formoterol PRN. The biggest problem with track one is we don't have FDA approved formulation of budesonide formoterol in the United States for rescue, and that probably contributes to the red tape. Now, track two says that you can use albuterol if and only if ICS is used at the same time. You could also use albuterol PRN if the patient is compliant with ICS LABA. How many patients do you think are really compliant with ICS LABA? Because if they're not compliant with the ICS LABA and they're using albuterol, now we're back to the problem to begin with,
Right.
which is they're using albuterol unopposed. And that is really where the risk comes in for increased and severe exacerbations. So it is a very much of a conundrum. With some of the patients who insist on albuterol, I will write ICS to be used as PRN with the albuterol. At least I feel like I'm compliant with the GINA recommendations.
Right.
In reality, is that patient going to fill the ICS or even use it? Probably not.
Yeah.
But at least I feel the obligation to do best practices. Now, the budesonide formoterol combination is a very interesting combination. For the listeners of this podcast, how is formoterol, the LABA, being used as a rescue? The key point for that is that all LABAs are not the same. The three FDA-approved LABAs in the United States, you've got salmeterol, formoterol, and vilanterol. Of the three, the formoterol is actually a fast-acting LABA. The onset of bronchodilation is equivalent to a short-acting beta agonist. So if you're wondering why you could get away with a long-acting beta agonist as a rescue, that's why. And compare that to salmeterol, which has an onset of action of 30 to 45 minutes. If a patient is using salmeterol as a rescue, they're going to go into respiratory arrest before the bronchodilation kicks in.
Yeah.
But that is why the formoterol budesonide combination can be used as rescue.
I'll be honest, I use it off label all the time. I find I have much better luck getting insurance companies to pay for the formoterol budesonide than I do the budesonide albuterol. And I tell people it's off-label, but it's been validated in clinical trials elsewhere outside the United States, and that it's perfectly safe to do so. And I think it's your best option.
Tracy, that is a concept called SMART therapy, and that's an acronym for single maintenance and rescue therapy. It actually works really well because if the patient's not compliant with the maintenance, they're still getting their ICS. That's
Right.
also the other reason why out of urgent care, I love the SABA ICS combination,
Yeah.
which is albuterol and budesonide, because the patient's going to get the bronchodilation from the albuterol, and they're going to get the budesonide when they use their rescue. So if they're not compliant with their ICS LABA, or if we need to defer that decision to the primary care team, I know that every time they use that rescue inhaler, they're getting ICS and they're going to get better outcomes.
Both of them make perfect sense because anytime somebody would use albuterol, you give them the steroid at the same time, and it's going to do the things that are going to make them need the albuterol less. I guess we should be clear that budesonide formoterol is FDA approved for asthma, but it's as a preventative medicine. It doesn't have the FDA approval as a rescue, but it can function as that, honestly, for the reasons you said. It's rapid onset. People begin to feel relief almost as quickly as albuterol. I've had patients take puffs in front of me, and within a minute or so, they are feeling some relief from that. Whereas your other LABAs, it takes a lot longer for that to kick in.
Joe, that's what's really unique about the formoterol. It's a fast-acting LABA.
Yeah.
Keeping that in mind, a lot of the guidelines and a lot of what the patient reports with these medications that make sense.
How about systemic corticosteroids? You talked about how they're important. We're always cautioning people about stewardship, which doesn't mean you never do something, but you balance the risks and benefits. This is one of those indications where they're worth the risk, right? When should we be considering them for patients? Does it matter? PO, IV, IM, you mentioned PO. And what about the difference between X and prednisone, prednisolone? Can you kind of flesh that out a bit more?
I've used prednisone just because I'm used to it. It's 40 to 60 milligrams a day. You can either taper or you can burst it, 5 to 7 day burst. You do not get adrenal cortical suppression with those short term. Dexamethasone does have some advantages and is preferred in other cases, particularly with parainfluenza virus or croup. There's some advantages of that, but I think sometimes clinicians just get used to what they are used to. Some people will use methylprednisolone, which, as far as I'm concerned, when someone comes into urgent care with an acute asthma exacerbation, it's too late. You need steroids. That is not the time to go, hey, you're wheezing, you're short of breath, but we're worried about corticosteroid stewardship, so we're going to withhold that. No, that is not the time to do that.
Right.
Okay? Standard of care is corticosteroids to break that acute asthma exacerbation.
Cool.
This is the one time I get off that soapbox. You know, there's maybe 7 things that steroids are absolutely necessary for, and this is one of them. Don't be on that soapbox for asthma. It's perfectly okay to give steroids to asthma. Not only is it okay, it's actually significantly indicated with multiple randomized controlled studies saying that you can actually save somebody's life with it. Just go ahead and give those steroids. There were a couple of things mentioned in the article about the Dexa that I just wanted to mention. The dosing for that, the studies showed, was 1 dose in the clinic and then maybe a dose the next day. And that's extremely beneficial when you have somebody that you think maybe isn't reliable, or you don't think they're going to pick up the meds, or you think they will stop after 2 days for whatever reason. Because if we remember that it's a longer acting corticosteroid than the prednisone, so you'll get a little bit of a benefit from it a few days out, even after you discontinue it. I like to give it in the clinic because I use the injectable form, SPO. I think it has a faster onset of action than giving somebody a tablet. So I usually like to provide that. And it's a small volume, so it tastes gross. But you can mix it with some other things to make it a little tastier. What about the conundrum of IM steroids?
Tracy, I rarely use IM steroids.
Yeah, me too.
I was always taught that because IM still has to go through first pass metabolism, it actually doesn't work any faster compared to PO.
It's minutes.
I think what you hear is that the bioavailability of both of those are the same. The only time you would want to do that is if the person can't take something PO. Maybe they're so reckless that they can't take it PO, or they're vomiting at the same time, which, gosh, what a nightmare that would be, right? Asthma and vomit at the same time. But yeah, otherwise it's not any better. And Trace, you mentioned using the IV formulation orally. How about that? Hey, I can inject this, but no, I'm going to give it to you by mouth. there is a Dex elixir that's not very concentrated.
It's a huge volume.
And it's totally fine, we know, actually, from pharmacists to give the injectable dexamethasone oral and just mix it with some juice. Hey, there was a pretty robust kids bits section this month. Somebody else authored it, so I don't know how much you guys were involved in that, but can you summarize the overlap or any differences in terms of how we should treat kids versus adults with asthma exacerbations?
I think the biggest conundrum with kids is that there is no FDA-approved ICS rescue under 18.
Yeah.
Yep.
That's the biggest conundrum.
Yeah.
So the acute treatment and the urgent care is exactly the same. We don't do anything really different with kids in the urgent care, but trying to figure out what to discharge them with, that's a little more challenging.
Cool. And then one final thing that I thought was pretty interesting. You guys highlighted the difference between exercise-triggered asthma and exercise-induced bronchospasm. A lot of times people, and even for a long time myself, thought of them as the same thing, but there is a difference. It's probably what the inflammation that goes along with it versus just pure bronchospasm, right? Is this the one time that somebody can just use plain albuterol maybe? Or what's your approach for those two different things?
The challenge is, Joe, you're absolutely correct. If it's pure EIB, exercise-induced bronchospasm, it is not inflammatory. There's no inflammation. So in pure EIB, the standard of care is 15 minutes before exercise, use albuterol, and that should prevent the significant symptoms. But where our listeners may get confused is that exercise is also cited as a trigger of asthma.
Yeah.
And the two can be independent or the two can overlap. So a patient can have pure exercise-induced bronchospasm, in which case there's really no role in ICS. But a patient could also have exercise-induced asthma, which is inflammatory, where ICS is needed. Or the patient can have mixed. They got both. So what I teach and what I promote is, look, if someone has EIB and they seem to do well with albuterol pre-treatment, then that's great.
Yeah.
But if they don't seem to do well, or they seem to have symptoms that don't really resolve, then you got to consider that there is probably a component of inflammation and you may need to add an ICS.
Yes. Yeah.
I'm hoping the patient will know, and you can just ask them, are your symptoms only when you exercise versus you have symptoms at other times when you're not just exercising, to be able to tell the difference. Obviously, you're not going to hurt somebody by just giving them albuterol, but you could certainly tell them if it's unclear. Maybe go back to your primary care doctor or your asthma specialist and talk about your action plan and ask if maybe you should have inhaled corticosteroids. But I find those are the patients that I frequently get coming in and asking me for a refill because they use it infrequently. Maybe it expired. Maybe they don't have a primary doctor anymore. Maybe the thing was sitting in their car for 2 years and the label's all rubbed off with no expiration date on it because it's been rolling around the glove box. So err on the side of caution, but you're always willing to refer them back to their primary and patch them up as best you can in the short term.
I really want to put in some more talk on the dangers of oral corticosteroids. We're not saying don't use oral corticosteroids if indicated. And I want to reemphasize that in an acute asthma exacerbation that presents to urgent care, oral corticosteroids are the standard of care. Withholding that is actually not following standard of care.
It's harmful.
Yep. The reason why we are emphasizing ICS rescue on an outpatient basis or at home is because the goal is to decrease the risk of exacerbations, which translates into decreased need for oral corticosteroids.
Right.
I think if you look at some of the data with regards to albuterol, budesonide, there is a mean annualized corticosteroid reduction in both intermittent to severe asthmatics. In terms of the actual corticosteroid risk, as little as 500 milligrams of total lifetime prednisone equivalent, you're going to start seeing some permanent risk increase. The one I could recite right off the bat is the increased risk of diabetes at 500. But by the time you get to 10 grams of steroid use in a lifetime, you see an 8-fold increase in osteoporosis, increased risk of diabetes, sleep apnea, thrombolytic events, glaucoma, cataracts, and these are real. So if you have an asthmatic that receives 60 milligrams of prednisone a day for 5 days, that's 300 milligrams. You do that 10 times, you're already at 3 grams.
Yeah.
You do that 40 times, you're approaching the 10-gram limit. This is the long-term side effects of steroids. That doesn't include the short-term side effects of steroids, which is increased risk of avascular necrosis, as well as an increased risk of septicemia.
Yeah.
And so throwing these steroids out is not necessarily benign. And if you are throwing it out for asthma, it's defendable because that is the medical indication. But if you're basically writing prednisone because someone has a cough and they don't have asthma, that could be problematic.
Oh, it is. Yeah. And all the more reason to emphasize proper care when the patient's feeling well so that it decreases their chance of exacerbation, like you said.
Yeah.
There are some diseases that we use steroids for that we have no ability to prevent or alter how often somebody's going to need them. But this is one that we can help with, so we should.
Absolutely.
Great. Thanks, Chris, for joining us. Appreciate it.
Yep, very much.
Guys, thank you.
Do we know what we have next month?
Next month is drug rashes.
Oh, cool. Drug ration. That's going to
Yeah.
be great. Lots of pictures. We'll have to be very descriptive on the pod. Thank you very much, Chris. Guys, take care. Bye-bye.
Bye-bye, everybody. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site. That's evmedicine.net to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.